Thank you, Professor Kuo, for the kind introduction. I also like to thank Professor Kudo for inviting me. You know, Hokkaido is always my favorite. I've been here for several times, countless. I can't even remember. So today I'm going to talk about how AI can assist our cognitive neuroimaging. So this is my disclosure as one you just mentioned. I'm the founder of the DeepRay.ai. The company was founded last year, and we are so lucky to be picked by NVIDIA to be one of the, sitting on the top, one of the Taiwan partner to NVIDIA. So as a neuroradiologist, we know most of the neurodegenerative disorder or disease is non-specific. Quite pity, non-specific. But some of the disease follow some characteristic pattern. As you can see on the left corner, here is IMPH. It's a typically floating brain, narrowing of the superior convexity. South side is very typical, and ventricular dilatation. For the semantic type of progressive, primary progressive aphasia, you can see dominant left temporal atrophy. Okay, this is some characteristic pattern. So you can see the answer right here. But today, I'm going to talk about three types of cognitive impairment condition. Of course, first is INPH. The second is post-concussion syndrome. The third is brain age and cognitive prediction using different MR technology. So, INPH is dementia. We know it's reversible, and the image is quite typical. Patient had communicating hydro without drastic elevated CSF pressure. As you can see here, the corpus callosum outward bone is quite typical. But importantly, we remember that within the 12 months of symptom onset, this is the typical period for shunt response because the aqueduct stroke volume CSF tend to increase, then decrease after this window. Then the brain develop, the central atrophy. So it becomes a good opportunity for AI using imaging biomarker to classify if the patient is responsive to permanent VP shunting. In the standard routine, the patient has to be admitted to do the lumbar drainage. Is quite invasive. So we tried deep learning, and we, to extract the feature from 2D and phase contrast flow dynamic. So it's quite simple that we can do auto-segmentation of the CSF space, and we can extract the, aqueduct flow parameter. So we can utilize in those parameters to train our deep learning algorithm. This is just one case to show you that when the patient responds to VP shunt, the patient gets symptom improved after shunting, but the morphology and the CSF dynamic only improve slowly. So after 12 months, you see the morphology, ventricle remain dilated, but the velocity increased close to normal. Okay, we proudly use dual CNN model, and we have very small, the false positive and false negative. But even we want RSNA magnet count lottery. We want it, but this is the fail example. We never built a model for clinical application. We're just happy with the analysis and the process. Second, I will move to some kind of a little bit successful example, concussion and working memory. The temporal evolution of mild traumatic injury from acute, primary injury, the diffusion axon injury, followed by secondary injury, the neuroinflammation, neurodegeneration, then later on patient may develop cognitive impairment, even early dementia. This is Never before a good opportunity. 100,000 papers have published regarding the structure and functional connectivity disruption and also brain atrophy quantification. So there are ample of startup company, they offering some boost your brain programs that you can do something that prevent your brain going down, okay? So the question is, why should I pay for this program? Or should I spend time daily to prevent my post-concussion syndrome? So that's a main need. So this is our research that we followed through the patient post-concussion to 1 year. As you can see here in the patient side, this is the NBAC. The patient's, the working memory decline at the beginning, then gradual recovery at 3 months, then fluctuate to decrease at 12 months. This is a bumpy, fluctuating working memory, typically for longer, prolonged post-concussion syndrome. If you look at the working memory deactivation, you can see the concussion patient, they lost the ability to suppress default mode network all the way from the beginning to the end. So this is the patient with prolonged post-concussion syndrome. In computer modeling, the rotational acceleration produces maximum shear stress around the core of the brain. So the core is thalamus. So in a nutshell, the pathophysiology of the mild concussion injury, though the traditional, conventional neuroimaging is all negative, but patient actually had thalamocortical circuitry disruption. Then patient may get some, like your heartbeat, arrhythmia, this is thalamocortical dysrhythmia. Then patient develop all kind of different kind of post-concussion syndrome. So this is a very important concept that thalamocortical pathway is critical in relaying and integrating our memory, cognitive, and somatosensory information. We use high-resolution tensor imaging to segment the subnuclei of the thalamus. And we also do the subnuclei-based tractography. As you can see here, the blue color tract is somatosensory, and the yellow is the motor pathway. So we have a bunch of the information. So now we can compute the thalamocortical coherence. Each pair of the thalamic and cortical, the low frequency can be calculated to be some coherence by Dr. Sun. So this kind of a coherence can be all to put together into a connectome color map. That's if you are normal without concussion, your color is something like this, random color. And you can also do the thalamo is a triangular random color. But in patient with concussion, and you predict the patient will have prolonged post-concussion syndrome, they will pathologically enhance the low-frequency temporal coherence. That means the connectome color become all red. We report this last year in Progress in Neurobiology. And we build a model for this. Bear with me. I'm sorry, there's no sound here, but can we adjust the sound a little bit bigger? Okay, let me do the caption. Okay. You just scan, like 10 minutes, and we reconstruct it, in 2 or 5 minutes, we can generate auto-report to tell if you are going to have prolonged post-concussion syndrome. That's simple, that's easy, but we all use the thalamocortical coherence pattern. So we build up the software, and we are currently trying to get the clinical validation and to be a product. Okay, lastly, I move very fast. Lastly, most importantly, Global agents, the cognitive resilience. Somebody like me, age above 60, we are struggling with cognitive resilience. We always forget somebody's name, forgot my key. Where's my key? Okay, so when do you decide to do the brain workout to beat the cognitive decline? Why should you spend all the money and time to fighting with cognitive decline? Here is the reason. Dementia is a pandemic because of global aging issue. As you can see, the staggering number here, 2050, although I'm not going to live up to 2050, but it's, very, very scary. Although there are some new drugs for delaying cognitive decline, but there are several restrictions. One of that is very expensive, and the effect is limited. You see the first, Leqembi is only 27% slowing down. And also there's a risk for hemorrhage and brain edema. We know the area H, area E, Neuroradiology got very busy when those two drugs come into Taiwan. I think one year will be, reading a lot of MRI because each time patient visit the hospital to get the injection, they have to do the, MRI to count the microbleed, 3 bleed or 4 microbleed. It's a very, busy. But it's only for delay cognitive decline. But we change for another perspective. For somebody like me, between age 60 to 75, it's stretching, 15 years without early dementia. You don't have to get an injection. For the early 60, you will probably encounter subjective cognitive decline. A little bit, I still can work, but a little bit. But as the time went on, you probably can get into the early MCI and late MCI. How can you do for yourself to prolong, to delay the progress of the cognitive function? There are several, paper, science, neuroscience, cells. There are a lot of big paper published regarding how to do this. One of these, the 40 hertz, 40 and auditory stimulation. Some other like, again, Lumoxity is a big company, and some supplement like curcumin or recently ergothioneine. So it's kind of amino acid that not produced by human, but you can get it to improve your cognition. So this is Lumosity. Are you going to spend money to play the game every day, each time 20 minutes, for 5 days a week? You wanted to do this? Please use our product, Deep Brain Coordinator. We use the generative AI to produce the 4D, brain, predictive model. So this is generative AI, as I just heard the sweep MR, they use the noise to produce the enhanced imaging. Probably something related to GAN or diffusion model, I don't know. But actually, generative AI, they can produce the new imaging, realistic, fake imaging, or they can enhance original imaging or generate new imaging like VAE, variational autoencoder. This is our method that you put in the original data, encode, and become the latent vector, then decode, then become the new data. Why we use this? So here is our algorithm that we use the 3D gradient equal T1 as encode as the latent vector. We also incorporate patient's age, gender, aquaporin 4, and other family history into the latent vector space, then we decode. So in the training process, we use, again, adversarial, to enhance the image quality. Then we can predict patients' 3D, from the first year, second year, third years, all the way. That's called 3D like a cinema. Okay, so long story short, Deep Brain Coordinator have 3 models. The first is that we can use the 3D image to predict your brain age, not your biological age, your brain age only. And your brain atrophy pattern, quantification of your cortical brain. The third part is to predict your cognitive decline next year. If you are going to this direction, that you begin to play with Lumosity software every day, 1 week, 5 days. Are you going to do that? Okay, this is our interface because we design. We do the study to think about massive screening, not just for particular subject. And this is preventive medicine. So any health screening entity who use our software can see, in the morning we have 6 subjects here. You can immediately identify subject 6. Number 6 has, brain age problem, have some kind of atrophy pattern, and patient going to be early dementia and probably need some shot. Okay, for the brain age, this female, 70 years old, and he's, our model predict his brain age is 77.43. His brain age much older than his biological age. So, because usually if you use a big data to train the brain age prediction, there is always some, standard deviation or error margin. Our error margin is like a 2.99. It's the lowest in the benchmark, because here are some other study using different data set. They have those errors between the 4 years to 6 years. So ours is the lowest. The next is the predicting future dementia. Actually, secretly telling you that we are training the imaging and the CDR, the number, to predict the future CDR, not the future 3D images. But I keep it as a secret here that we will, in this software, we will reconstruct the future 3D imaging. But we can tell you that if your CDR is falling in the category of MCI, late MCI, or early dementia. Okay, this is the 6th category for CEL Soundbox. Okay, this is a particular patient who followed from his age of 77 to 88 when he became demented. You can see how close the fitting we got, to each, time point. This is the years, the time point of different brain region that the cortical thickness become, thinner with age, and our prediction is very close to the actually what happening here. So, of course, this is auto-reporting, just one click, everything, printed out. Actually, we need a doctor sign this, so physicians have to look at the data. If everything's okay, the subject is black, is white, or Asian. At least you have to check this. And the age, then, follow through. Then, one click, you will have the report. Okay, see, here is one case study. Let me tell you how we can improve radiology work. This is a 73 male with cognitive decline. He had MMSE26. Clinically, already been diagnosed early, MCI. So here is some standard, clinical imaging radiology well read. You can see a patient had mild cortical atrophy and no microbleed. And this is the radiology report. See now change, cortical atrophy. Maybe you can add some, MTA score or ERICA score. But importantly, because when you report this, atrophy, all are non-specific. And, 10, 15 patients will probably convert to dementia next year. So we can't get this by, just a naked eye, a visual reading. With deep brain coronado, you can see we estimate the age is much older for brain age for his biological age. And the patient, 1 year risk is from very mild dementia to mild dementia. And the atrophy patterns just tend toward the Alzheimer pattern. So patient can immediately to play the game from today to prevent the next year thing, So this is the important thing, that the patient can do something for him or herself. So this is our interface that we can reconstruct 3D in just 2 to 5 minutes. And all those are color 3D. And we can immediately to prioritize which cases have those problems, and physician can advise the subject or the patient to take on his lifestyle change. So this is deep ray AI. So this is my take-home message. We understand that medical AI holds immense potential in the field of cognitive care. All those must be integrated with clinical unmet need. And AI research should be product-oriented from its inception. So it's very important to understand that if you do one thing, just 1 ounce of prevention, it may worth a pound of a cure. Thank you very much for your listen.